pancreatic duct. And this is the contrast enhanced computed tomography scan showing carcinoma of the head or the pancreas. This is carcinoma of the head or the pancreas. This is magnetic resonance cholangiopancreatography, MRCP. Please, dear students, MRCP without contrast. ده تشوفوا هاي الصورة كلش واضحة، بس هاي بدون كونتراست. ده تشوفوها طلاب هاي الصورة. طلاب واضح هاي الصورة؟ عافية. هذه بدون كونتراست طلاب، اللي يشوف أول مرة واحد يقول لي هذا بيها كونتراست. لا، هذا بدون كونتراست. MRCP نسميه MRCP magnetic resonance cholangiopancreatography. This is without contrast. The bile itself looks like contrast. Okay, the bile itself acts as a contrast. So this is without contrast. MRCP, magnetic resonance cholangiopancreatography. There it is very clear obstructive jaundice. طبعا to start with obstructive jaundice, we investigate the patient by ultrasound. If there is dilatation of intrahepatic bile ducts, we can go further do MRCP. There will, it is very clear dilated common bile duct, and there are stones in the lower common bile duct and stone in the neck of the gallbladder. This is the ERCP, endoscopic retrograde cholangiopancreatography. It is an endoscope passed through the mouth, to the esophagus, the stomach, the duodenum, and through the second part of the duodenum. Okay, in the second part of the duodenum, we can introduce a catheter and do contrast study. We can do it is used as a diagnostic and therapeutic. Also, we can pass retrieval of the stone, removal of the stone. Dormia basket, we use Dormia basket, or we can put a catheter. We can take biopsy. We can do sphincteroplasty. And so this is for diagnostic and therapeutic, ERCP, endoscopic retrograde cholangiopancreatography. And this is also ERCP shows pancreatic carcinoma. These are irregular structures of the main pancreatic duct. This is the pancreatic duct, and it's a very clear picture. There is irregular structures. And definitely, when there is structure, there will be a proximal dilatation. So there is dilatation distal to the obstruction due to carcinoma of the head or the pancreas. And this is another picture of ERCP, shows malignant structures in the lower part of the common bile duct. And it shows very clearly the main pancreatic duct, which is called double duct sign. This is another picture of ERCP, shows what we call it chain of flakes, because of multiple distinction structures in the pancreatic ducts. In cases of a chronic pancreatitis, there is a long structure of the pancreatic duct in the head, with distal pancreatic duct shows circulation and intervening short structures. So there is structure and proximal distinction, structure and proximal distinction, structure and proximal distinction. So it is called chain of flakes. سلسلة البحيرات. واضح طلاب؟ واضح هاي الصورة؟ واضح طلاب؟ تسمعوني؟ الله يخليكم عيني.
اي نعم دكتور واضح.
تمام. أشكرك عيني. This is another picture for a plain abdominal X-ray, just a plain abdominal X-ray of the abdomen. It also, in cases of chronic pancreatitis, it shows multiple opacities. As I told you, we can do FNA through either ERCP or through endoscopic ultrasound. And this shows adenocarcinoma cells, pancreatic juice collected at the time of endoscopic retrograde cholangiopancreatography. So during ERCP, we collect pancreatic juice and send for cytology, and this shows diagnostic malignant cells. This picture shows carcinoma of the pancreatic of the head by endoscopic ultrasound. Endoscopic ultrasound, it means through gastroduodenoscopy, we pass it through the mouth, esophagus, stomach, and to the duodenum. And this endoscope contains a probe for ultrasound. So we call it endoscopic ultrasound. And also we can carry out uh, aspiration biopsy and pass a needle through the tumor. This is the needle pass through the tumor. It is very clear. So these are the morphological study and investigations of pancreas. We said that also we can send for serum amylase. You know, amylase, it's one of the enzymes secreted by the pancreas. But not always elevated serum amylase reflect cases of acute pancreatitis. There are many other conditions that causing increase in the serum amylase. For example, upper GIT perforation. I mean, perforated peptic ulcer, for example, mesenteric infarction, torsion of an intra-abdominal viscous, retroperitoneal hematoma, ectopic pregnancy, macromelissemia, renal failure, salivary gland inflammation. All these conditions causing increased and elevated level of serum amylase. So it is not specific for acute pancreatitis. Now we study the diseases of pancreas. First of all, we start with congenital abnormalities. I told you previously that any disease it may be either congenital, traumatic, inflammatory, neoplastic, or miscellaneous. So, in the congenital anomalies, we have a lot of congenital anomalies of the pancreas, like cystic fibrosis, pancreativism, annular pancreas, ectopic pancreas, and congenital cystic disease of the pancreas. These are congenital diseases of pancreas. Definitely, you are studying in the congenital anomalies of the GIT. Regarding injury of the pancreas, it is not either external injury or iatrogenic injury during surgery, during splenectomy, for example. In the external injury, always common because the pancreas is retro behind the stomach, the retroperitoneum behind the stomach. So injury of the pancreas definitely associated with injury to other abdominal viscera, and usually it is severe injury. So other organs like liver, stomach, bowel, mesentery bleeding, spleen, maybe intraperitoneal bleeding. So usually it is associated with other major injuries to other abdominal organs, like in cases of car accident, shell injury, of course. In our country, a lot of shell injury disease. The most important thing in cases of injury to the pancreas is to ascertain if the pancreatic duct has been disrupted. The major problem of pancreatic injury is pancreatic duct disruption. And this can be diagnosed by CT scan or ERCP, endoscopic retrograde cholangiopancreatography, the most useful test to diagnose if any pancreatic duct disruption. Surgery definitely is indicated if the main duct is disrupted. And this is very important. This CT scan shows pancreatic transection due to a bicycle handlebar injury. يعني هذا شخص على البايسكل وبالبايسكل صار عنده تروما وبالحقيقة صار transection to the pancreatic duct. This is treated by distal pancreatectomy. Pancreatic fistula, the management of pancreatic fistula, we should first of all use test, measure amylase level in the fluid, and determine the anatomy of the fistula, and check if the main pancreatic duct is blocked or disrupted. So the measures correct the fluid and electrolyte imbalance, protect the skin, because these enzymes cause excoriation of the skin, and you must do drain adequately. And the patient may need parenteral or nasojejunal feeding, octreotide to suppress secretion, and relieve pancreatic duct obstruction if possible by ERCP and stent. As I told you, ERCP, endoscopic retrograde cholangiopancreatography, used as a diagnostic and therapeutic. So in these cases, we can use it as therapeutic. We put a stent, a catheter, and also we must treat the underlying case. What are the underlying causes? Now, after this, we discuss the pancreatic congenital anomalies and pancreatic injury. We discuss pancreatitis. Acute pancreatitis, it is very important subject. There are a lot of patients presented to the emergency department with acute pancreatitis. It is very important to exclude other diagnoses because the pancreas is behind the stomach. So first of all, to start with, these exudate and inflammatory process are behind the stomach. The patient may complain of severe abdominal pain, but with little physical signs to start with. There may be soft abdomen to start with, until this inflammatory fluid from the pancreas escape through foramen of penicillin to the general peritoneal cavity and causing abdominal tenderness and rigidity. But the most important thing is to exclude other possibilities of acute abdomen. Okay? The causes of acute pancreatitis, there are a lot of causes of acute pancreatitis. The most common two causes are gallstones and alcoholism. Gallstones is the most common cause of acute pancreatitis. That's why patients with gallstone, we advise him for surgery, as we discussed this previously, because one of the complications of gallstones are acute pancreatitis, regurgitation of a fluid and causing acute pancreatitis. Also, alcoholism is very important cause of acute pancreatitis. Other causes of acute pancreatitis are post-ARCP. After ARCP, endoscopic retrograde cholangiopancreatography, this may cause acute pancreatitis. Or abdominal trauma, especially in children. Yeah, in children, not only especially really in any patient, but I mean in children, they are playing football or they are during playing, maybe trauma, maybe fall on the ground or any trauma, okay? They may present with acute pancreatitis or they may present as a complication of pancreatitis, like pancreatic cirrhosis. We will discuss it later on. Other causes of acute pancreatitis are any surgery, biliary of upper gastrointestinal or cardiothoracic surgery. Ampullary tumor, a tumor in the ampulla of water may also cause acute pancreatitis. Drugs, very important. Please, there are a lot of drugs causing pancreatitis, like steroid, azathioprine, thiazide, and estrogens. Hyperparathyroidism, hypercalcemia, also causing acute pancreatitis. Congenital anomalies causing acute pancreatitis, like pancreas deficit. Also, there are autoimmune pancreatitis. This is very important. Autoimmune pancreatitis and hereditary pancreatitis. These are very important because it's very important to ascertain why is this patient developed pancreatitis. We should look for the cause. Also, viral infection, mumps and Coxsackie virus, malnutrition, cyclopean bite. So there are a lot of causes of acute pancreatitis, and it may be idiopathic, but we cannot ascertain that this is idiopathic. We should look for the primary cause to treat it, to prevent recurrent attacks of pancreatitis. This is very important. So if the patient presented with acute pancreatitis and definitely diagnosed and definitely diagnosis by investigation pancreatitis, it is not enough to treat the patient. We should look for the primary cause and treat the primary cause to prevent recurrent attacks. So it is essential to establish the etiology, investigation thoroughly before labeling it as an idiopathic. And after the acute episode resolve, remember further management of the underlying etiology to prevent recurrence. If the etiology is gallstones, for example, cholecystectomy is desirable. Maybe during the same day or same period of admission, it may be relieved because if you only treat the pancreatitis, the presence of gallstones, there may be another source escaped from the gallbladder and through the common bile duct and causing recurrent attacks. So the patient cannot be improved without removal of the gallbladder. Definitely the patient presents with severe acute abdominal pain. It is very severe. It is acute pancreatitis is an autodigestion. These enzymes causing autodigestion and inflammatory process. And as I told you, because the pancreas is retroperitoneal behind the stomach, so first of all, these inflammatory fluid collected in the lesser sac behind the stomach. So they are not in contact with the parietal peritoneum of the anterior abdominal wall. So to start with, there is very severe abdominal pain, but with little physical signs. Till these inflammatory fluid pass and escape from the lesser sac through the foramen of Follisto to pass to the general peritoneal cavity and becomes in contact with the parietal layer of the anterior abdominal wall. In this condition, there will be abdominal tenderness, rigidity, maybe rebound tenderness, gardening, rigidity. So the symptoms till these ones. The most important thing to do differential diagnosis. This acute severe abdominal pain may be due to other conditions need immediate surgical intervention. Maybe due to perforated peptic ulcer, for example. This is one of the differential diagnosis, very important. So investigations in acute pancreatitis should be aimed at answering three questions. Number one, is a diagnosis of acute pancreatitis correct? Or the patient may have other pathology, like perforated peptic ulcer or other disease. This is very important, because the patient presented with acute abdomen. Number two, how severe is the attack? This is very important. We have parameters I will discuss to you later on, in the next slides, how we assess the severity. Always, please, my dear students, if we have a patient with pancreatitis, inflammatory process, or maybe a malignant disease, we should investigate the severity of the condition. Regarding malignant disease, we should investigate the staging of the tumor to know how to treat the patient and to know the prognosis. So very important, we have two parameters to assess the patient severity, patient's severity of the acute pancreatitis. And third question, we should ask about the etiology of acute pancreatitis, because we should treat the primary cause, like gallbladder sauce, autoimmune drugs, etc. Because without treating the main cause, the main primary pathology, there will be recurrent attacks and causing destruction and of pancreas with a lot of sequelae, bad sequelae. So in the investigation of acute pancreatitis, you should answer three questions. Number one, is a diagnosis is correct? Number two, how severe is the attack? And number three, what is the etiology? In the assessment of severity, it is either mild, moderate, or severe. What does this mean? Mild acute pancreatitis, we have a measures. It is not only just one say this is mild or moderate. No. In mild cases, there is no organ failure and no local or systemic complications, because acute pancreatitis may be associated with organ failure and may be associated with local and systemic complications. So mild attack of acute pancreatitis associated with no organ failure and no local or systemic complications. In cases of moderately severe acute pancreatitis, there will be organ failure that resolves within 48 hours, what we call it transient organ failure, and or local or systemic complications, but without persistent organ failure. In this condition, we label this as a moderately severe. But in severe acute pancreatitis, there will be persistent organ failure, more than 48 hours, single organ failure, or multiple organ failure. واضح طلاب هاي الاسسمنت of the severity of pancreatitis till now؟ واضح الشرح؟
نعم دكتور واضح.
أشكركم. Now this is the assessment. شكرا جزيلا. لا حول ولا قوة بارك الله فيك. Now assessment of cases of acute pancreatitis. We have either Ranson or Glasgow scoring system. Ransom scoring system depend on admission, the age of the patient the patient age above 55 years, the white cell count, white BC more than 16, the blood glucose more than 200 milligram per deciliter, serum enzymes LDH more than 350 units per liter, AST more than 250 units per liter, and within 48 hours, the hematocrit fell of 10% or greater. Blood urea nitrogen rise more than 5 milligram per deciliter. Arterial oxygen saturation, PaO2. Serum calcium less than 2 millimole per liter, because there will be calcification and spherification and decreased cerebral calcium. Base deficit more than 4 millimole per liter, and the fluid sequestration more than 6 liters. This is the Ransom scoring system for the severity of acute pancreatitis. Another scoring system, we call it a Glasgow scoring system. In this Glasgow score, within 48 hours, the age of the patient also more than 55 years, white BC more than 15, blood glucose more than 10 millimole per liter, LDH more than 600 units per liter, serum urea more than 16, arterial oxygen saturation less than 60 millimeter mercury, serum calcium less than 2 millimole per liter, and serum albumin less than 32 grams per liter. And the investigation imaging of the patient with CT scan, we use contrast enhanced CT scan is indicated in the following situation. Number one, if there is diagnostic uncertainty, if we have a suspicion, doubt of pancreatitis, the patient may have pancreatitis, but also there are other differential diagnoses. The patient may have, as I told you, perforated peptic ulcer. So this condition, he need immediate surgery in cases of perforated peptic ulcer. So if you have suspicion and not sure of a clinical diagnosis, we should document this and prove it or disprove it by CT scan with contrast. Other indication for contrast enhanced CT scan in patients with severe acute pancreatitis. Why? To distinguish interstitial from necrotizing pancreatitis. Sometimes this auto digestion pathological process of pancreatitis may cause necrotizing pancreatitis. It is a very severe condition, hemorrhagic necrotizing pancreatitis. In the first 72 hours, CT scan may underestimate the extent of necrosis. And number three, patient with organ failure may be signs of sepsis or progressive clinical deterioration. Also, when a localized complication is suspected, such as a fluid collection, or pseudocyst, or pseudoaneurysm, in these conditions, we need CT scan enhanced, with contrast study for assessment of the severity of acute pancreatitis. This is the picture of contrast enhanced computed tomography scan. Patient with acute necrotizing pancreatitis. Look, it is very clear. There, it is a picture reduced enhancement in the pancreas with peripancreatic edema and surrounding of the fatty tissue, what we call it acute necrotizing pancreatitis. Pancreatitis is an autodigestion and causing severe damage to the whole pancreas. And this is what we call it fat necrosis due to pancreatitis. Widespread fat necrosis of the omentum. There will be a blood-stained peritoneal fluid rich in amylase, and fat necrosis are dull, opaque, yellow-white area. Okay, most abundant in the vicinity of the pancreas. This is to start with, and may be widespread in the greater omentum and the mesentery. But if the condition is very severe, necrotizing hemorrhagic pancreatitis, which may be fatal. There are a lot of complications of pancreatitis, really. There may be even respiratory distress syndrome, because the pancreas is retroperitoneal, and these inflammatory fluid may pass to the mediastinum, to the chest, and causing respiratory distress syndrome. And there are a lot of patients died due to severe necrotizing acute pancreatitis. So if the patient died at necropsy, they can sometimes be demonstrated the fat necrosis even beneath the pleura and pericardium, and even in the subsynovial fat of the knee joint. تخيلوا الطلاب، يعني هو هذا لذلك نقول local and systemic manifestation. So acute pancreatitis is very serious. If it's a severe condition, necrotizing, hemorrhagic, may be fatal. There are also small islands of what we call it saponification, caused by the liberation of lipase, which split into glycerol and fatty acids, and the free fatty acids combine with calcium to form SOP, what you call SOP, fatty necrosis. So acute pancreatitis is an autodigestion. The lipase secreted by the pancreas, causing splitting of the fatty acids into glycerol and fatty acids, the fat, and causing free fatty acid combined with calcium, forming saponification and fat necrosis. واضح طلاب الفاتي necrosis والسaponification in case of acute pancreatitis؟ واضح طلاب؟ واضح هاي الصورة؟
واضح دكتور.
أشكركم عيني، شكرا جزيلا. So how we manage these patients? These patients, as we, as I told you, it is very severe and may be fatal, causing respiratory distress. The inflammatory fluid pass from the pancreas, which is retroperitoneal, may pass to the mediastinum, causing respiratory distress syndrome. So they need admission to the high dependency unit, or what we call ICU, intensive care unit. Intensive care unit or respiratory care unit or high dependency، يعني الإنعاش الجراحي بالحقيقة. Not CCU. It's CCU regarding the heart, but this is, we call it ICU يعني or high dependency unit, intensive care unit. It's very important for monitoring of the patient, because the patient may develop respiratory distress syndrome and may leading to death of the patient. The patient need an analgesia, aggressive fluid rehydration because of loss of fluid, hypovolemia. So he needs replacement therapy. Also supplementation of oxygen, invasive monitoring of vital signs, central venous pressure, urine output. The patient may need Foley's catheter, for example, blood gases assessment, and frequent monitoring of hematological and biochemical parameters, including liver and renal function, clotting, serum calcium, blood glucose, white BCV. These are for assessment of the severity of pancreatitis, as we mentioned. Also, maybe rest of the pancreas, we may use nasogastric drainage and G-tube. Antibiotics if cholangitis suspected in cases of gallstone pancreatitis. Patient may need prophylactic antibiotics. CT scan is essential if organ failure and the clinical deterioration or signs of sepsis develop, because these inflammatory fluid prone for inflammation and causing peritonitis, which complicate the case. ERCP within 72 hours for severe gallstone pancreatitis or signs of cholangitis. If the cause of pancreatitis documented that it is due to gallstones, by MRCP there will be it is shown that gallstones in the common bile duct. In this condition, ERCP, therapeutic ERCP, we can do it and pass a catheter, what we call it Dormia basket or Fogarty biliary catheter, and removal of these gallstones. Also supportive therapy for organ failure if it develops, like inotropes, ventilatory support, very important, and hemofiltration. If nutritional support is required, consider enteral nasogastric feeding. So the condition may be very severe. So there may be systemic complications, local complications, Acute pancreatitis may be peripancreatic fluid collection and sterile and infected pancreatic necrosis. So the complications of pancreatitis, it is either systemic complication or local complication. Local complications usually develop after the first week. Systemic complications more common in the first week, during the first week. These systemic complications, either cardiovascular complications, maybe shock, and maybe arrhythmia. That's why the patient needs to be managed in the ICU, in the intensive care unit. Also, pulmonary complications, acute respiratory distress syndrome. There are a lot of causes of adult respiratory distress syndrome. One of these, in acute pancreatitis, I told you that this inflammatory fluid and exudate of pancreas, which is retroperitoneum, pass upward to the chest, to the mediastinum, and causing respiratory distress syndrome. Also, there may be renal failure and hematological complication. There may be DIC, disseminated intravascular coagulation. And you know, DIC, it is very serious. Maybe in the portal or vein thrombosis. DIC, it means there is consumption of the clotting factors in the blood. There may be bleeding, at the same time, there may be thrombosis. Disseminated intravascular coagulation or coagulopathy, DIC. It is very serious condition. Also, there are metabolic pseudoaneurysm, hypocalcemia because of precipitation of calcium and causing fatty necrosis, as I told you. Hyperglycemia, maybe hypocalcemia, deficiency of serum calcium, and hyperglycemia, hyperlipidemia, gastrointestinal ileus, maybe ileus, due to this exudate and inflammatory fluid, what we call it prophylactic syndrome, يعني prophylactic reflex of the bowel, ileus, paralytic ileus. In neurological complication, there may be visual disturbances, confusion, irritability, and even encephalopathy. And there are other serious complications like subcutaneous fatty necrosis and arthralgia. So there are very serious complications, systemic complications of acute pancreatitis, which are common in the first week, during the first week, first few days of the attack of the condition. The local complication of acute pancreatitis may develop after the first week, like acute fluid collection, sterile, to start with pancreatic necrosis, which is autodigestion, lipase, amylase, okay, protease, these causing sterile pancreatic necrosis. Later on, this pancreatic necrosis may be infected and become infected pancreatic necrosis with production of pancreatic abscess, cirrhosis, pancreatic ascites, and even pleural effusion. So it is very serious condition. It may be fatal in severe conditions. And there are a lot of patients really died in the ICU. This is CT scan shows infected pancreatic necrosis. There, it is very clear there are area of reduced enhancement in the pancreas with peripancreatic fluid collection and pockets of gas within it. طبعا this condition resolved after percutaneous drainage and antibiotic therapy, either under ultrasound or under CT scan guide. Under ultrasound or CT scan guide, we pass a needle through the abdominal wall and do a drainage, percutaneous drainage, because this inflammatory fluid is highly toxic. A lot of enzymes, autodigestion, and may become infected. So we do percutaneous drainage and antibiotic therapy. So pancreatic abscess, pancreatic ascites, pancreatic effusion, hemorrhage, portal or splenic vein thrombosis, cirrhosis. These are serious complications of pancreatic acute pancreatitis. Cirrhosis may develop later on. It is pseudo. Pseudo, it means not true cyst. The true cysts contain endothelial cells. But this cirrhosis, there is no endothelial cells. It is just collection of inflammatory fluid. And because the pancreas is behind the stomach, so this is affecting the stomach. We use previously burial meal, causing displacement of the stomach by pancreatic pseudocyst. And we have a lot, for example, children presented with abdominal mass. And these are children may have a previous abdominal trauma, and this abdominal trauma causing attack of pancreatitis, and this is a complication of it, development of pseudocyst, which is diagnosed very well by burial meal. So this pseudocyst has complications. This pseudocyst either as a complication by infection, it will be converted to an abscess, and later on leading to systemic abscess. Other complications, if this pseudocyst rupture into the gut, causing gastrointestinal bleeding or internal fistula, or may rupture the pseudocyst into the peritoneum, causing peritonitis. Or the pseudocyst may get enlarged in size, causing a pressure effect, obstructive jaundice from biliary compression or bowel obstruction. And if the pseudocyst enlarged, causing abdominal pain. Or this pseudocyst may cause erosion into a vessel, causing hemorrhage into the cyst and hemoperitoneum. So the pancreatic pseudocyst has a lot of complications, and it needs treatment. A treatment, we call it, we anastomose this cyst maybe with a stomach, what we call cystogastrostomy. Cystogastrostomy. Previously, we do it, can be done even during with a laparoscopic surgery or by endoscopy. Cystogastrostomy, and it's anastomosis between the pseudocyst, which is behind the stomach, in the pancreas behind the stomach, with the stomach. We call it cystogastrostomy for the pancreatic pseudocyst. The anterior wall of the stomach has been opened, and the aids drawn back, held by Babcock forces. An opening has been made through the posterior wall of the stomach into the pseudocyst, and the tips of the dissecting forceps are in the cavity of the pseudocyst, which is lined by slough, just a slough and granulation tissue. That's why it is called pseudocyst, not a true cyst, because the lining not endothelium, but the lining is just a slough and granulation tissue. And so we call it pseudocyst, not a true cyst. Then running stitch, we suture it, the next to be placed along the edge of this opening, and suturing the full thickness of the posterior gastric wall to the capsule of the pseudocyst. So how we distinguish a pseudocyst from cystic neoplasm? If the patient is presented with pseudocyst or cyst in the pancreas, this is maybe pseudocyst due to attack of a pancreatitis, but also it may be cystic neoplasm. There may be underlying malignant disease. This by history of the patient with pseudocyst have previous attack of abdominal pain and attack of pancreatitis. Also appearance on the CT scan and ultrasound, fine needle aspiration, as I told you, and show you the picture of malignant cells by FNA, preferably under endoscopic ultrasound guide. As we mentioned, we have endoscopic ultrasound. Gastroscope contain a probe for ultrasound and another probe for FNA. So this endoscope, once we pass it through the stomach, through the mouth, to the esophagus, to the duodenum, stomach and the duodenum, we can pass, we have a probe of ultrasound, what we call endoscopic ultrasound. And also we can pass a needle and do aspiration of this cyst and study the cells, maybe malignant cells. Also, we can do carcinoembryonic antigen. This is a tumor marker, high level in eosinophilic tumor, and amylase level, usually high in pseudocysts, but occasionally in tumors. And this cytology will show this is if it is pseudocyst or cystic neoplasm. as we mentioned, واضح طلاب